Good afternoon, everybody. I'm Olfa Hamzawi. I'm intensivist in intensive care Antoine Béclair Hospital from Paris-Saclay University Hospitals and a member of the cardiovascular session in ESICM. I'm very pleased to chair this webinar from the ESICM supported by GE Healthcare around fluid responsiveness. And as you know, in critically ill patients, the decisions to give fluids is a big issue at the bedside for all the physicians who try every day to find the good balance between, in one hand, not inducing fluid overload, and the other hand, not missing hypoperfusion due to a real need of fluids. The decision to give or not fluids should not be taken lightly, and I'm sure that after this webinar, you will have the right keys for this daily deal. In this webinar, we will have the opportunity with our international experts to discuss, firstly, how to differentiate between the need of fluids and fluid responsiveness, and secondly, the appropriate use of non-invasive method to assess fluid responsiveness. So you can send your questions directly on the ESICM TV or via ESIGM Facebook and YouTube account, and we will have time to answer them after the two talks of our experts. So first, I have the great pleasure and a big honor to introduce one among the most recognized experts in this field, Professor Xavier Monnet. Professor Xavier Monnet is Professor of Intensive Care in the Medical Intensive Care of Bicêtre Hospital from Paris-Saclay University Hospitals in France. He is also the chair of the cardiovascular session of the ESICM, and he will talk about the need of fluids versus fluid responsiveness. So please, Xavier.
Thank you very much, Alpha, for your very nice and kind introduction. And before starting, I disclose my collaboration with Pulsion Medical Systems Göttingen and with Baxter. You're right, it's not a light question, but what are we speaking about exactly? Let's think about a patient, for instance, with septic shock on community-acquired pneumonia on day 1. In this patient, the PF ratio is low, the blood pressure is low, the PEEP is elevated, and the patient has already received 1.5 liters saline and is under norepinephrine. Blood pressure is still low. Should we give fluid to this patient or not? This is, you will agree, the daily question. The first issue we have with this treatment is that all the patients do not respond to fluid administration through the expected increase in cardiac output. Initially, this was totally ignored, but when colleagues started to measure cardiac output at the time with the pulmonary artery catheter in the 80s, they observed that some patients had no increase in stroke volume. This is the first study, I think, showing that after fluid administration. And after this first study of Calvin and co-workers, many of them and many since this first study reviewed here 20 years ago, many studies confirmed that half of the patients only respond to fluid administration through a significant increase in cardiac output, and likely you know that. And the main reason is basically physiology. As if we give fluid administration, actually we expect that stroke volume and cardiac output increase. In this way, we use the cardiac output relationship, the Frank-Starling curve at the bedside. But basically, you know from your first years at medical school that the slope of the Frank-Starling curve basically depends on the ventricular function. And this explains why the same fluid administration with the same volume of fluid may lead to a significant or a negligible increase in cardiac output. It means that fluids are not fluid responsiveness. These are totally different concepts. It's not because you give fluid that your patient will respond to fluid. Is that really an important issue? For years, it was not that sure, but today we know all the drawbacks, all the adverse effects of fluid administration in our ICU patients, and likely in the operating room patients as well. The effects of fluid are not constant, and even more when you give fluid, and that it does not increase cardiac output, it has only adverse effects. Mainly, it increases lung water, it increases lung edema, it promotes intra-abdominal hypertension, it reduces hemodilution, it promotes also right ventricular failure, etc. And more than theory, we know that's been clearly demonstrated today. Just to show you one study, the first that's been clearly showing that in septic patients, the sub-analysis of the SOAP study, definitely the total amount of fluid administered, the cumulative fluid balance, is an independent predictor of mortality in these patients. The more fluid you give to these patients, the more they die. And so we are left with these two issues in constant effect and potential harmfulness, which means, by the way, and confirms, by the way, that fluids are drugs. We should logically predict fluid responsiveness before giving fluids. Just as antibiotics, fluids are drugs with several adverse effects and an inconstant efficacy. If you try to predict before giving antibiotics whether they will be effective or not on the germ you want to treat, the same, you should test fluid responsiveness before giving fluid to your patient. In fact, in our mind, we are drawing this very simple algorithm. Is cardiac output too low? Urine output is low, lactate is elevated. Should I give fluid? There are two cases. In the minority of cases, you know that the patient will be fluid responsive because fluid losses are obvious, because it's the very early phase of septic shock with obvious relative hypovolemia. In these cases, definitely you should not try to predict fluid responsiveness, because it is very likely in these cases you should give fluid and that's all. But in the majority of cases, in all the other cases, you know that only half of the patients will respond positively to fluid administration. It means you should look at indices that will tell you before starting fluid infusion that the patient will very likely be fluid responsive. And as you know, for this purpose, static markers of cardiac preload as central venous pressure, for instance, are not valuable at all, and we should look for dynamic indices. What are we speaking about? This concept of dynamic prediction of fluid responsiveness is in fact very, very easy. It's a way to assess the slope of the cardiac function curve at the bedside. I mean, you change preload, or you observe spontaneous changes in preload, for instance, fluid administration, effects of ventilation, etc., and you look at the changes in cardiac output, stroke volume, or surrogates. If the change is significant, then you can give fluid, being sure that the patient will respond to fluid positively. Otherwise, you refrain from fluid administration. And during the last 20 years, several indices were developed to predict fluid responsiveness in a dynamic way. And I suggest that together in the next minutes, we review all these indices, methods, and that we together consider their advantages and drawbacks. Definitely the easiest way to assess fluid responsiveness is just to give fluid and look at the response. It means a fluid challenge. Give 300 or 500 milliliters to your patient and see how he or she responds. It's very easy to do. Two main drawbacks. The first one is that bear in mind that to correctly assess the response of fluid during a fluid challenge, you must measure cardiac output. If you look just at pulse pressure, arterial pressure, it is not reliable enough. You need to directly measure cardiac output. But even more importantly, inherently fluid challenges that perhaps many of you like a lot induces fluid overload. This is inherent to the method you use. Why? Because it is not a challenge, it's the treatment itself. I mean that you give fluid to a patient, and if the patient does not respond, you go on with the next bolus, etc., until the last bolus that does not increase cardiac output and stroke volume anymore, and then you stop fluid administration. This is basically the fluid challenge. Let's imagine a patient as the one we spoke about at the beginning. Septic shock with ARDS on first day. You will agree with me, your patient will experience perhaps 5-6 episodes of hypertension, which means that obviously this induces fluid overload. You cannot remove the fluids you've given to your patient, and definitely the fluid challenge is not a challenge, it's the treatment itself. This is why the concept of giving small amounts of fluid, 100, 150 milliliters, a mini fluid challenge might be interesting, and we now have some positive studies. My point regarding mini fluid challenge is that it requires a precise measurement of cardiac output. What do I mean? This is the first study of some French colleagues showing the interest of this mini fluid challenge. 1 milliliter of starch, and these patients could discriminate responders from non-responders. Nevertheless, small amounts of fluid can only induce small changes in cardiac preload that can only induce small changes in cardiac output. And in this study, these small changes were detected by echocardiography. We will speak about that likely later with Dr. Sanfilippo, but is cardiac echo reliable enough, precise enough to detect so small changes in cardiac output? Likely not. I'm even sure that it's not the case. Because the smallest change that you may trust with echocardiography in the velocity time integral in this estimation of stroke volume is 10% only. Smaller changes, you're not sure that it will be detectable with accuracy. That's why for this mini fluid challenge, I would much better rely on some more precise techniques for measuring cardiac output, cardiac index, as for instance, pulse contour analysis or other continuous methods. And for instance, in this study by the team of Mathieu Vier in Bordeaux, they showed that pulse contour analysis detected the mini fluid challenge effects. Look at the change in stroke volume less than 10%, 6%, which is compatible with the precision of pulse contour analysis, not of echocardiography. Anyway, it still requires to give fluid to the patient that you cannot remove. As all of you know, pulse pressure, stroke volume variations that have been developed 20 years ago are very reliable indices of fluid responsiveness, but on the other side, we can use them in a minority of patients, and the main circumstances, situations where we cannot use these indices because they are not valuable anymore are cardiac arrhythmias, spontaneous breathing, even in an intubated patient, spontaneous ventilation, and ARDS because of lung compliance, low lung compliance, and low tidal volume. And the problem is that it's likely a very large proportion of our ICU patients where we cannot use PPV and SVV. Nevertheless, we can say that there might be a solution in the specific case of ARDS with the low tidal volume, which is that tidal volume challenge that's been developed 4 years ago by Dr. Mayatra and some other Indian colleagues. And the principle is very simple. No need to measure cardiac output. You just increase the tidal volume from, for instance, 6 to 8 milliliters per kilogram, and look at the induced changes in pulse pressure variation. And if if pulse pressure variation increases by more than a given threshold, it's very likely your patient is fluid responsive. In this first study, we showed that the threshold was a 3.5% increase in ppv. Nevertheless, some other studies found smaller thresholds, as the one we just published in critical care, where we show that the threshold was a 1% increase only. So I think that further studies should try to refine the threshold of the tidal volume change. The changes in the diameter of inferior IVC, superior SVC, vena cava are very popular indices. I think that many colleagues like it a lot. Actually, you don't need to measure cardiac output or VTI or stroke volume. Just look at the changes in the diameter of the vena cava. First drawback, you must know how to do that. Nevertheless, it's very easy to assess it, at least the IVC. SVC is much more complicated. You need TEE, it's not easy, but IVC, definitely it is very easy. My point here is that keep in mind that these are the less reliable indices of fluid responsiveness we have. It's today very clear. Many small size studies showed that, and many meta-analyses of this study confirmed that. Even more, we have a 2017 large French negative study. Look, in that study, the ability of the changes in the IVC to detect preload responsiveness was very low. The area under the RAC curve was only 0.65, which is very low. So it is well demonstrated, and likely it can be explained why. Why does, for instance, the IVC change with ventilation in fluid responsive or preload responsive patients? Did you think about that already? It's not only due to the slope of the Frank-Starling curve. I mean that if it changes, it's likely because, yes, the intramural pressure, the CVP, changes in case of preload responsiveness. But the change also depends on other factors: the compliance of the IVC, the intra-abdominal pressure, and so the transmission, the degree of transmission between the thoracic and the abdominal pressure. It's not only related to preload responsiveness. And I think it is the reason why it has a so low predictive ability. In addition, these changes in vena cava diameter share most of the limitations of PPV and SVV. Do not use it in patients with low tidal volume and spontaneous breathing. And expiratory occlusion test perhaps you've heard about that test that we developed years ago with Jean-Louis Teboul in this study. The principle is very easy. It's all about heart-lung interactions. Indeed, in a patient with mechanical ventilation, you agree that each insufflation tends to impede venous return. It decreases cardiac preload, and then the next cycle stops. The cycle stops, preload increases. Next insufflation, preload decreases, etc., etc. And so the principle of the test is that if you stop mechanical ventilation for a few seconds, for instance, 15 seconds, you increase cardiac preload for a few seconds. And if in turn stroke volume increases, it means that both ventricles are preload dependent. The duration must be at least 15 seconds or 12 seconds, because the preload ballast must cross the pulmonary circulation, and also the cardiac output monitors we use must average this change in cardiac output. And today we have several studies showing that there is a good level of reliability. We performed this meta-analysis a few months ago with Francesco Gavelli. You see the threshold is a 5% increase, and look at the area under the RUC curve, 0.95 compared to IVC changes. It's totally different. It's very easy if you have a direct display of cardiac output under your eyes, for instance, with pulse contour analysis again, or any other technique. With echocardiography, it is possible, but since the threshold is low, and because of the precision of echocardiography, we showed in this study that you need to add to the end expiratory occlusion an inspiratory occlusion that will enlarge the induced changes with a higher threshold, but that will make the changes in cardiac output induced by the test detectable by echocardiography. Of course, it's not possible to use it in patients with a strong respiratory efforts. They interrupt the occlusion. And again, you need something that measures cardiac output. It's difficult to measure with blood pressure only. Let's end up with the passive leg raising test that likely you know. Many studies have shown that it is a reversible preload challenge. On average, the volume is 300 milliliters of blood, but it's very variable from one patient to another. But it's a pseudo fluid challenge. I would like to insist on 2 points, 2 last points regarding the passive leg raising test. The first is that you need something that measures cardiac output to perform the test. Unfortunately, if you use arterial pressure, and especially arterial pulse pressure, it's not very reliable. Then you need something that measures cardiac output. And many studies have looked at reliable ways to perform the test in a non-invasive way, because of course you can use pulse contour analysis, but of course all the patients are not equipped with such systems. Esophageal Doppler, not easy in the ICU. Echocardiography, you look for an increase in the VTI by more than 10%. Capnography, I don't have time to show that, but it's interesting. Bioreactance is reliable. Changes in carotid flow, I think it is not reliable, but again, no time to insist on that, because I'd like to speak about plethysmography. SpO2 to assess the effects of passive leg raising. This PLET signal that we have under our eyes every day, in fact, is made of 2 parts. There is a pulsatile systolic part of the signal and a non-pulsatile portion that you don't see on your screen. And the ratio between both is called the PI, the perfusion index. And you can easily understand that it has 2 determinants. The first one is vasomotor tone. Of course, if the patient is vasoconstricted, the PI is low. But also stroke volume, because it will increase the pulsatility of SpO2. So is it possible to use that amplitude of SpO2 to assess the effects of, for instance, passive leg raising or a fluid challenge? I don't show all the details of this study that we performed, but look, the changes in this PI were able to detect the changes in cardiac output induced by passive leg raising and volume expansion. And for instance, in this fluid non-responder here, there was no change, neither in cardiac index nor in perfusion index. So SpO2 to detect changes in cardiac output during passive leg raising. Be careful, we had to exclude some patients because the signal was very unstable. We showed recently that the PI can also detect the changes in the end expiratory occlusion test. We need some confirmation, but likely a way which is costless, non-invasive, and widely available to assess changes in cardiac output in these tests. Finally, you may use just PPV, which is displayed on your screens, for instance, during passive leg raising, as we showed recently. Finally, less reliable in case of intra-abdominal hypertension. Likely, there was less volume in the abdomen, less possibility to less volume to mobilize during the test. It's been suspected for years that it may induce some false negatives, and we confirmed it in this study published 2 years ago. In patients with intra-abdominal hypertension, fluid increase, volume expansion, increased cardiac index, passive leg raising to a lesser extent, meaning that there might be some, not all, but some false negatives in these cases. So I think the best dynamic ways to assess fluid responsiveness might be the mini fluid challenge, the end expiratory occlusion test, and passive leg raising. Thank you very much for your kind attention.
Thank you,